Shall I start?
Yeah, let's go for it.
Greetings. My name is Laura Lorenz, and it's my great pleasure to introduce this webinar today, which will focus on two Photovoice projects in Uganda and the United Kingdom. This webinar is being recorded and will be posted on the department's YouTube channel soon. The Photovoice method, a major part of my community work and research since 2000, is an amazing way to communicate using photographs and dialogue. The photos are created by people we want to learn from and with. Each Photovoice project is different, yet each one leads to new connections and understandings, both emotional and cognitive. Somehow, Photovoice always manages to cross chasms that exist between and among us in education, language, and experience as our differences melt away when we discuss the photos and the experiences and emotions they represent. The Photovoice method was developed in 1992 by Carolyn Wong and Marianne Burris as part of a large regional development project in Yunnan, China. They wanted to ensure that the knowledge and perspectives of village women throughout the province would inform decisions about investing the development funds. That very successful project has informed the many thousands of Photovoice projects that have taken place throughout the world in the more than 30 years since. The steps of Photovoice, as described by Carolyn Wong and others, involve training co-researchers in ethical principles of research on their lives and communities, taking photos to answer research questions, discussing their photos and experiences with others, developing captions or descriptions, and advocating for positive change. Originally created for public health and development work, Photovoice has evolved for use in clinical care and training and therapeutic purposes. It continues to be a major method for social justice, as we will hear about today. In 2019, I co-founded Photovoice Worldwide, a small business with my partner Russ Dingley, after dreaming about creating this company for almost 20 years. My colleagues and I facilitate training and mentoring in the method, and we seek to create a community of practice where people around the world can share their knowledge, enthusiasm, and expertise with their peers through continuing education activities. Last year, for example, we worked with the Pakistan Institute of Living and Learning, which has funding from NIHR to improve the lives and services for people living with burn scars. Check out our blog posts, coffee chats, webinars, conference recordings, and so on. And reach out to us at info@pvww.org if you would like to connect. We'd love to hear from you. Today, first, we're going to hear from Byamah Mutamba, who is a member of the Executive Committee of the Board of Directors of the World Association of Cultural Psychology. He has degrees in medicine, public health, and a doctoral degree from universities in Uganda, the UK, and the Netherlands. Today, we will be hearing about his work in Uganda to transition institutionalized individuals living with severe mental illness and epilepsy back to their families in a Wellcome Trust-funded study. Secondly, we will hear from Roisin Mooney, a senior postdoctoral fellow and project manager in the CHiMES collaborative group in the Department of Psychiatry at the University of Oxford. Often her work focuses on foregrounding the experiences, the voices of people with valuable lived experience. She will speak about the COPACT study for which she was PI. Following each presentation today, we will have a brief Q&A, just one or two questions, and please post your questions in the chat. And at the end, if there's time, we will have more questions as well. Thank you so much, and Byamah, I invite you to start. Byamah, I think you're still muted.
Thank you, Laura. Sorry about that. I'll now proceed to share. And as I plan to share, I greet all of you. I am Byamah Mutamba. I have been introduced. And I'll be presenting on Photovoice in Uganda. I'll kindly ask you to let me know if you can view my slides.
Yes.
And if they'll keep moving. This is work that we've done in Uganda. And I'll start by giving a context to what I do, to what we do in Uganda, and what Photovoice we're going to talk about today. And it will focus on work that we are doing in collaboration with people with lived experience of psychosis, that we are implementing as You Belong, an organization in Uganda, a community-based non-government organization, and in collaboration with the Center for Global Mental Health Equity at the George Washington University and funded by the Wellcome Trust in the UK. And like I said, I'll start by talking about Uganda and the mental health services in this country. This is a country in East Africa with a lot to offer, but with the same challenges in mental health services that you would find anywhere else. What you see is a picture of the National Referral Mental Hospital, Butabika, where I work, a beautiful place, and the national level hospital. Later on, I'll talk about the hierarchy of our services, where we offer services to especially those with severe mental disorders, including those with alcohol and substance use disorders. Now, this is a hospital which is designed to have 550 bed capacity. But at any one time, since the turn of the year, we have over 1,300 inpatients. And the health worker to patient ratio is rather large and with very few workers to many patients. What this causes is really a state of institutionalization, especially for the individuals who come in for care. Where they lose self-respect, they lose their agency, their dignity, in many ways, just because they are really institutionalized. And that causes a sense of despair, hopelessness, and mostly loss of personal identity. And that's not because the inpatient care is not offered, but because many who are offered care and become well are unable to go back to their communities because of social, economic factors, but mostly disconnect with their families.
Byamah, I think we're still on your first slide. I don't know if they were meant to move along when you were talking about the hospital.
Okay, I think that is because, but you can hear my voice, hopefully.
I can hear you. Yeah,
I think I'll do it in this version.
Perfect.
Can you see the next slide?
You see the second slide, third slide. Yeah.
Thank you. Yeah, it usually does this. So I talked about the institutional care and the problems that causes at the national level services. And I just got to try and explain to you how the services are organized in our country, because the hospital, the National Referral Hospital, is at the apex of the pyramid. That's how it's supposed to be organized. And then there are different levels below that, including a regional referral hospital, a general hospital, and different levels of health centers, and then the community, where we have community health workers that are referred to as village health teams. Now, in the second column, you can see the level of staffing. What I try to illustrate is the lack of human resource, specialist human resource for mental health services at the various levels, and what they are able to offer as services, which translate into inadequacy in terms of volume and quality of care. And what this eventually translates to is the gap, the mental health treatment gap across the continent, and probably in most low, middle and income countries, where they suffer the widening mental health treatment gap. And this is especially so for severe mental disorders. The mental health treatment gap actually touches on a lot of the spectrum of mental disorders, but the severe mental disorders have an even wider gap where up to 90% cannot access care. But where they access care, they're mostly institutionalized, like in our setting in Uganda, where that's where they're able to get the treatment that they needed at an earlier stage of their illness. And like I already mentioned before, what institutionalization does is that it creates stigma, it creates loss of dignity and personal identity. And so with that in mind, as You Belong Uganda, we felt that to address the treatment gap in African settings and other low resource settings, we needed the low-cost, scalable, and easily integrated interventions within the existing health systems. Just to take a step back, so You Belong Uganda, with the context in mind which I've painted, has a focus on improving the lives and well-being of people with severe mental disorders in Uganda and the region. And we aim to design evidence to strengthen community mental health services and move beyond facility mental health services. And that's what led to the setting up of You Belong Uganda in 2017. So for the last 9 or 10 years, we have been implementing the You Belong Home intervention, which is a community mental health intervention that relies on a multidisciplinary team of social workers, community nurses, and occupational therapists to help transition individuals with severe mental disorders that are ready to discharge from the institution, that is the mental hospital, back to family and community. And what you see is really the conceptual diagram of the You Belong Home intervention. And why I'm mentioning this is that it actually informs the study that we are conducting, and I thought it's important that we have this understanding. The You Belong Home intervention entails a pre and post-discharge process. And what you see before you are hospital pre-discharge assessment processes, which are conducted by the You Belong Home multidisciplinary team. We then have a home pre-discharge assessment while the service user is still in hospital. And thereafter, we have a preparation for discharge and supported discharge using the multidisciplinary team and support and transport to help the service user go back to a prepared family. And when they get back to the family, then they have, together with the team, a process that involves planning for their recovery, and mostly through empowerment that relates to providing information through psychoeducation and providing skills related to management of difficult behaviors, livelihood skilling, and addressing stigma. So that is the pre and post-discharge intervention. And because of this experience, we designed the strengthening care in collaboration with people with lived experience of psychosis study. And that's really the focus of the presentation, where I'll talk about the use of Photovoice by the service users with lived experience, not only of psychosis, but recovery through the You Belong Home intervention. So this is a Wellcome funded study, a pilot cluster randomized study, whose aim really is to evaluate the role of people with lived experience of psychosis, focusing on how feasible and acceptable it is to work with them at different levels to improve outcomes. And it's premised on the evidence so far, and which is really well captured in the last World Mental Health Report that promoted the use, the engagement and empowering of people with lived experience. And that's what informed our idea of SCAPE-U. SCAPE-U was also informed by work done by my colleague with whom we collaborate on this project, Professor Brandon Court at GWU, together with his team, who did the reshape studies in Nepal. And this informed especially the use of Photovoice. But for SCAPE-U specifically, it targets 3 levels. And like I said, as you belong, we work within the health system to improve outcomes outside facilities. So it targets engagement with people with lived experience at community health worker level, at primary health facility level, and at the household level. And at each level, there are outcomes, because this is a study, a controlled study, where we look for specific outcomes that translate into the ultimate goal of improved outcomes for service users and family. Briefly speaking, because we want to get to the Photovoice aspect, like I said, it's a randomized cluster control trial that is a pilot and focusing on assessment of feasibility and accessibility. And we use the MRC framework for complex interventions to design it. It had a contextualization phase to refine the study and then actually conduct the cluster RCT over a period of 18 months. It's a 3-year study, and it's conducted in central Uganda in the districts of Kampala and Wakiso. So in everything that we've done, the person with lived experience of psychosis, whom we call a SCAPE-U facilitator, is involved at each level. And specific for this presentation is that their role, if I may go back a bit, was that they would be involved through the use of Photovoice in training community health workers, in training primary health workers, and then in delivering psychosocial support at the household level using Photovoice. And later on, I'll now detail how we've actually used the Photovoice. So the SCAPE-U facilitators, that is persons with lived experience of recovery through the You Belong Home program and with lived experience of psychosis, are trained on how to actually use Photovoice. That means understanding the concept of Photovoice, learning how to comfortably tell their stories, and learning how to use a camera and take photographs that depict their story of illness and recovery. And that's what I'm going to next. So here, what we see is some of the SCAPE-U facilitators, with their permission, because they are part of the study team, training community health workers and primary health workers. We use the MHGAP implementation guide for both arms, the intervention arm, which is the SCAPE-U, where the persons with lived experience, the SCAPE-U facilitators, are involved, and then the treatment as usual arm, where we have where we don't have the SCAPE-U facilitators involved, and we want to compare the outcomes. So these are SCAPE-U facilitators who have been trained and supported by the You Belong Home team as their supervisors to train the different cadres. Thereafter, the training, because the primary beneficiaries are persons who are recently diagnosed with psychosis at the primary healthcare level, are then supported at the household level together with their carers by the SCAPE-U facilitators who use Photovoice and who use Photovoice to actually offer some support, psychosocial support. And this psychosocial support, which now going strict into the Photovoice, is premised on the You Belong Home post-discharge empowerment program. The stories and photos are designed to tell the recovery story, and then they are developed together with the You Belong Home team, and the photographs are taken by the SCAPE-U facilitators to tell the story of illness, treatment, and recovery. And they also speak to 4 themes of information about psychosis, how to deal with stigma, how to deal with difficult behaviors, and then how to sustain yourselves from a livelihood perspective. So in my last part of the presentation, I'll talk about, I'll present a story, just an example of a Photovoice, Photovoice narrative and pictorial that one of the SCAPE-U facilitators has used as they continuously go to the family of the persons affected by psychosis and their carers to offer support. And so what you're seeing now is when the SCAPE-U facilitator had just developed illness where they had epilepsy with psychotic features. And what they aim to do is take a picture that really tells their story in the context and culture in which they live. And you can see that this is one of an anthill, because that's what the question is, why an anthill, and why this kind of anthill, and the explanation is there, because that reminded them of what it meant to be unwell, because that's the time they sought, the family sought alternative care. And then during treatment, there was an improvement in their health, especially their mental health. And so they felt like a blossoming plant, which had even begun to bear fruit. They felt alive again, and they had started to feel well. And that is what they aim to transmit to the recently diagnosed person with psychosis and their family, to give hope.
Very nice.
But during recovery, they also get setbacks. And in this case, this was a relapse. And the SCAPE-U facilitator aimed to depict a scenario where a building that was on the up suddenly collapsed and the bricks were all over. And so their aim is to communicate that relapse is part of recovery, and the importance of taking medication, especially in this case where the relapse was caused by a default in medication, and the ability to actually get back onto the recovery journey. And then the last picture, and I've just had a selection of pictures, but they have a variety of pictures that depict the whole recovery journey. This one is of a tree that they feel depicts how they relate to the recovery journey and what it means to live through recovery. So as I conclude, Photovoice is the medium that we use in SCAPE-U to engage persons with lived experience, to tell their story of recovery, and not only empower, but actually support treatment towards the recovery journey of not only theirs, but for those recently diagnosed with psychosis and their families. We are still conducting this study, not going into the details, and we hope to be finished by March next year, and we shall test the different outcomes. We have a number of outcomes, like I showed you, at the different time points. But it's important to note that the photographs and narration help to support different treatment needs, monitor recovery, and support others using their illness experience. Thank you for listening. That's the You Belong Home team together with the SCAPE-U facilitators. That's the end of the presentation.
Thank you, Byamah, for that wonderful presentation. And I so enjoyed seeing the narrative form that the photos and stories took for people working on your project. So amazing. Um, we welcome questions from the audience, either in the chat Q&A, or if you wish, you may speak up. Does anyone have any questions right now? Please raise your hand if you wish. Well, I have a question for you. I could start off. Dr. Mutamba, tell us, in that ongoing work at the community level, how does that work out? How often do the community health workers, stay in touch with people in their homes in the community? Is that a set process, or is it more, is it different for each person and each community?
Thank you, Laura. So I think what I didn't describe well was the different roles of the primary health workers and the community health workers. So the primary health workers are nurses, clinical officers, doctors who work at the primary health facility, and their job really is to offer assessments and treatments for people presenting to them for a whole range of illnesses. While community health workers are volunteers who mostly carry out a health promotion and preventive role. So they mostly go out to create awareness and sensitize communities on different diseases and health ailments. And so SCAPE-U is designed to work within this system and leverage the different roles. So the community health workers, by virtue of their roles, actually sometimes may or may not visit patients in their homes, depending on what their role is. And however, in the case of SCAPE-U, they are tasked with identifying, because they operate at a village level. And so in the event that they are informed of someone who might be presenting with signs of mental illness and specifically of psychosis, they visit, conduct an assessment, and then if they fit the criteria that we've provided to them, they refer to the primary health facility. After that assessment, if the person then arrives at the facility and meets the eligibility criteria of somebody with psychosis and fits the criteria to be enrolled into the study, then they are enrolled and started on treatment. Then it is after about a month, when they are stable on treatment, that the primary health worker reaches out to the SCAPE-U facilitator, the person with lived experience, to start the home visiting sessions. The home visiting sessions are conducted every 2 weeks over a 3-month period to offer support to someone who is receiving biomedical treatment for psychosis and some minimal psychosocial treatment from the health facility. And the community health worker can as well follow up the patient in the community at their own schedule, but the SCAPE-U facilitators provide the home visits with the support of the You Belong Home team.
Oh, thank you. And do the photos stay part of the conversations going forward so far?
Yes, so the photos, the SCAPE-U facilitators actually carry a flip chart with their recovery stories that include the photos and the narratives. So they have been trained to use the flip charts to narrate their story using Photovoice and tailor the needs of the service user and the family to their recovery stories. So it's the SCAPE-U facilitators alone who are using Photovoice, not the community health workers or primary health workers.
Okay. Well, thank you so much. We just greatly appreciate that presentation and your answers to these questions. Thank you. And now, Roisin, I invite you to present.
Hopefully now you can see my slides. So just to kind of preface this, in that the study that I'm discussing today is a study that was funded by the National Institute for Health Research. And any information shared in this in this presentation, represent the views of myself and are not necessarily those of the NIHR or the Department of Health and Social Care. So I just thought I would start off by talking a bit about why we chose Photovoice as a methodology for this project. And a lot of my work has often focused on working with kind of marginalised or excluded communities. So we wanted to think about using a method that was not similar to the traditional kind of quite potentially exploitative methods of doing research, such as using questionnaires or conducting interviews. A lot of the communities that we were looking to work with in this project can be quite mistrustful of researchers because they've often found that their stories have been kind of taken and used for other people's gain, or oftentimes people don't really hear back from what the outcomes of the research were. So we wanted to kind of step away from thinking about research as this very kind of onerous chore for people to participate in, and wanted to think about how we can conduct research in a more inclusive way and kind of really collaborate with and bring people along and empower them to tell their story. So we chose Photovoice as a form of participatory research, which kind of more broadly means that we're thinking about working with our participants in a more collaborative way. So it's thinking about balancing those power dynamics between the researcher and the participant, and how we can create kind of psychologically safe spaces that enable everyone to kind of come to the workshops being on the same page. So as Laura kind of introduced, and as I've kind of just mentioned here, the reason that we chose Photovoice as being different to other methodologies is this concept around sharing power and recognising participants as co-researchers. And thinking about images and captions and the kind of conversations around those are the data, and they kind of facilitate people to access their reflections, their memories and their stories in a different way. Often when working in research and kind of conducting interviews, we find that people have this sort of rehearsed narrative or a way in which they're used to telling their stories. And in this work, we were really keen to disrupt that, to think about allowing for kind of new insights and new conclusions. Often when taking part in this work, people shared with us that they'd kind of found a new language to use to talk about their experiences and share those with their loved ones. Which brings me on to COPACT. So this is actually a picture of Bobby taking a picture, who was one of our COPACT participants. COPACT was a study in the UK that was funded by the NIHR in response to the review of the Mental Health Act, which is the law in England and Wales that allows people to be detained in hospital when they become mentally unwell. There was a review in 2018, and we applied to do this research in 2019, and this research started in 2021. About 2 weeks ago, I actually went to the House of Lords in Parliament and presented some of the findings of this project alongside some other evidence that we're aware of to peers who are currently reviewing the mental health bill. So it just kind of reinforces how long it does take for change to happen, but also how impactful these stories and voices can be. And we know that people of Black and Asian ethnicity are detained disproportionately under the Mental Health Act, and that's what we were really, really interested in this project. So of the people that took part in Work Package 1, which is the Photovoice, 76% of those were from an ethnic minority background. So Photovoice is really central to this project. We started off by recruiting people who'd been detained under the Mental Health Act in the preceding 2 years. They contributed over 500 images and over 30 hours of audio, so we had an incredible amount of data to wade through. We also did Photovoice with staff as well, healthcare professionals, And that was really important to us, just because I think that their voices are often excluded from this conversation. It's really easy to think about the problems of the system and to kind of demonize the system, but we wanted to balance that and think about the people working within that system, and actually think about how we can all come together and work together to challenge some of these systemic injustices. So we started with the photo voice. We also collected data to find out what people thought about photo voice and what it was for them, what it was like for them to take part. We were often recruiting people who'd never really taken part in research before, and kind of had these perceptions around research as being kind of people in white coats taking blood or doing endless questionnaires. So we were really keen to kind of dispel that myth and to think about research as an opportunity to facilitate people to share their stories and inform change. All the information that we collected fed into some co-design workshops, and that kind of fed into a national event, which has resulted in some kind of policy outcomes. We are currently in the process of trying to publish some papers, and there's a couple of QR links in the presentation as well to various other outputs from the work. As I said at the beginning, we were really keen to conduct this research in a very collaborative manner. So as you can see by the kind of like little person icon throughout, you know, a lot of the workshops were co-facilitated with people with experience, and we had people with experience at all levels of the research, from being on the advisory board to being on the co-applicant panel. So this is more a slide to take at a glance, but it just gives you a bit of a flavour of how complex the population that we're dealing with are. So we were quite fortunate in this study that we kind of achieved exact 50-50 gender balance of men to women, which is this last blue column here. And then, like I said, 76% of our sample were from an ethnic minority background. About a third of our sample had experienced an adverse childhood event, and a third again had experienced a traumatic life event. And you can see the overlaps here. So I think about half of those were overlap, but often these were kind of separate things. 20% also had a physical illness, and quite interestingly, only 24% had an interaction with a healthcare professional before their section, and about a quarter of the participants had some sort of interaction with the police. Now, the real caveat with this piece of data is, with the exception of ethnic minority and gender, these aren't things that we proactively asked people for. During our photo voice workshops, we asked people to kind of tell us about significant moments in their life. And a lot of this data has been extrapolated from the different things that people felt were important to them. So photo voice is incredibly flexible, and has been used in lots of different ways, kind of as a clinical tool, as was previously described in the previous presentation, in research and in public engagement. In this instance, we were interested in using it as a research tool, although I do feel that the participants actually really benefited from taking part in the workshops. And we had 3 interactions with our participants. So we held a series of 3 workshops. In the first workshop, we really wanted to understand people's motivations for taking part and to share with them kind of our ethos around kind of why we were doing the work and what we hoped would happen with the results of the photo voice that we were doing. At the end of this workshop, we also gave people disposable cameras, and then they could go away and take photographs, and then we'd arrange to pick up the cameras in kind of a location that was central to them. This research happened in 6 sites across England, so there was a lot of travelling involved, and actually often we found that the postal service wasn't all too reliable in terms of getting the cameras back. We then got the photographs developed and we brought them to the second workshop, which is where we asked participants to kind of provide captions for the photographs. We worked quite closely with them to develop those. We also collected the roadmap and kind of demographic data in this workshop. And then in the final workshop, we kind of brought the participants together again and allowed them to have a conversation kind of amongst themselves. And we didn't have a topic guide for this, and it was very much led by which photographs people wanted to share with us. And this slide just shows you some of the feedback that people gave from each of those 3 workshops. So you can see that at the beginning, a lot of people kind of came to the workshops because they wanted to make a difference, and they wanted to get closure for what they'd experienced when they'd been detained under the Mental Health Act. But people also thought it sounded like something different, having fun taking photographs, but did have kind of some slight anxieties around what to take photographs of, or thinking about revisiting some quite traumatic experiences. But after the second workshop, kind of reflecting on the process of taking the photographs, I particularly like this concept of feeling in control, which I felt was quite important when recording kind of traumatic experiences and allowing people to kind of explore those to what extent they felt comfortable doing so. And quite nicely, by the end of the workshops, everyone said that they would recommend this methodology to others, which was really nice to hear, because it was something quite different, and it took quite a lot of kind of coaching really to get the kind of NHS trust that we were working with to recruit participants to doing research in quite a different way. So we analysed all of the Photovoice data, and from the patients we came up with 3 quite broad themes. It was interesting in this project, we kind of had to analyse the data for 2 different purposes. One was to really understand the experience of what it was like for these people, and the other was to inform the co-design workshops. So obviously for the co-design workshops, we wanted to have more of an overview of the data in quite an accessible format, so that people could really understand and kind of virtually step into these people's shoes and think about what it's like for somebody going through severe mental health problems and trying to access care. So the first concept that we talked about, and these are all photographs that were submitted to us with the captions, was around prevention and the challenges that people had in accessing care. A lot of people kind of told us stories about where they'd tried to seek help when they recognised that their mental health was deteriorating, but weren't able to, and had ended up then being in crisis and being sectioned under the Mental Health Act. There was a lot of talk around kind of alternatives to being sectioned, such as crisis houses, or day services, as well as kind of better mapping and understanding of what charity support was available in the local communities. The experiences of detention were really interesting. A lot of people shared with us very dehumanizing experiences. And I think there's a general perception that when someone's extremely mentally unwell, but they don't have any sense of self-awareness. But actually people really shared with us that they felt at the time that they were detained under the Mental Health Act, a lot of people did feel that that was necessary, but it wouldn't have been necessary had they been able to seek help earlier on. There were also a few incidences that had been escalated where people had felt unsafe and the police had been called, where perhaps they wouldn't have been detained or didn't feel like they needed to be detained under the Mental Health Act, but it was more around how others perceived them as a risk. A lot of people felt like they were being kidnapped, which oftentimes kind of fed into various forms of paranoia. This concept about the black van was shared with us quite a few times in different places, and often in the NHS, if ambulances aren't available, various security companies are contracted to take people to hospital when they're sectioned, which results in a black van coming to pick somebody up when they've had a Mental Health Act assessment. Not only does that have an impact on the person being detained, but also on the community, and kind of people really shared with us they needed a lot of support to kind of reintegrate into the community when people had observed them being kind of bundled into this black van. People often found it really difficult as well to recognise that they were in a hospital, because in England, kind of hospital staff and mental health units don't necessarily wear uniforms. A lot of them wear their own clothes. So even kind of waking up in an unfamiliar setting, being surrounded by people in their own clothes, it was really difficult for people to understand that they were in somewhere that was supposed to be caring for them. There was quite a large preference for being treated in the community in this research. The prison metaphor was really interesting, because a lot of people shared with us that being detained in a mental health hospital was like being in prison. That was until we had someone who had actually been in prison, and he said, no, prison's actually nicer, right? Being detained in a mental health hospital is way, way worse. And that, I think, really brought home to us just how much reform is needed in these systems. And this is just an example of some of the photographs that were submitted by one person. So you can kind of get a sense of the mixture of some quite difficult experiences, but also a lot of the kind of visuals were quite hopeful, quite green, quite bright. And there was a real sense of people kind of coming at this from a point of recovery. And then moving on to some of the staff photographs. I think initially I was quite undecided about how to present staff photographs alongside service user photographs, because I was really conscious of not wanting to undermine the narrative and the story that was being told by our service users. But actually, a lot of the time we found that the staff story really supported this. And in particular, I think this concept around the two chairs and really recognising that when a white man throws a chair, he gets sent to his room. And when a black man throws a chair, he gets restrained, injected and sent to PQ and locked in a room alone for 2 days. Kind of really hammers home just how aware the staff are of the situations that they're working in, and recognising that actually a lot of the staff that took part in this study and a lot of the staff on the units are also from ethnic minority backgrounds, and kind of recognising that they're working often in this quite racist system. And I think that does have a real impact on them. And even kind of just at a glance, you can see that a lot of the photographs that were shared with us from staff members were very black and white, very grey. And I think that was really representative of the fact that they're still working in these very oppressive, difficult systems, and really not very well supported and often working understaffed. And again, I thought this was quite a nice illustration of kind of the feel and the sentiment. Both of these images were submitted by the same healthcare professional. And then this is just to give you like a very kind of brief flavour of kind of some of the outcomes. So these are our policy recommendations that have come from the Photovoice data. So the Photovoice data was presented at co-design meetings, and then from the co-design meetings, we've kind of looked across the different action plans that were developed in different trusts. And overall, the 5 things that we're kind of hoping to change in the Mental Health Act is to have better public awareness of mental health, better mapping of community services and access to advocates. We feel that there needs to be better involvement with friends and family. A lot of the time, people felt really isolated from their friends and family when they were sectioned. We need to ensure that care plans are personalised. A lot of the time there were kind of national numbers or numbers that weren't felt to be quite relevant on people's discharge plans, and that was felt to be quite challenging. But I think most critically, we need to think about co-designing new standards of inpatient care, and really thinking about how dehumanising the system is and how we can support staff in changing that culture. And finally, I think it's really important that we recognise detention as a traumatic experience. I think often we think about hospitals as places that you go to get better, and I think it can be really difficult for friends and family to recognise and understand just how difficult it can be for people being detained under the Mental Health Act, that although they may kind of leave the hospital somewhat recovered from the mental illness that they went into hospital for, there's probably also been some quite difficult and challenging experiences within that recovery process. And just finally, this is one of the images from one of the Photovoice exhibitions that we had. And it was really nice to kind of see all sorts of people, from clinicians to policymakers to service users and their families, come and engage with the images. And we've got about 50 or so A3 foam boards printed, and we've displayed this exhibition in a couple of different places now. And it's always really interesting to see the different types of conversations that it sparks. And then just finally, I think this, although this was an image and a caption from one of our participants, I think this sentiment that mental health can affect anybody really came through quite strongly in all of the Photovoice data that we gathered. All of the images are currently displayed on our website. There is also an audio documentary and a video that accompanies all of the data as well. And that's everything for me. Thank you very much.
Thank you, Roisin. Another amazing presentation, so informative and so system-based. I think so much can be accomplished when you're embedded, all of this research is embedded within a system. Okay, could you please, here's a question. Could you please share about some of the steps taken to reduce the impact of inherent hierarchies or power dynamics between researchers and co-researchers on the caption creating process?
Yes, of course. So a lot of our workshops have been co-facilitated with people with lived experience, and I think that has really helped to, I guess, validate our intentions around listening to and empowering and elevating the voices of the participants in the room. We also often made sure that we were holding workshops in spaces away from NHS settings. So we often use kind of community buildings, art workshops, museums, all sorts of different kinds of creative spaces, which I think was really, really important. I think there's kind of a lot of kind of trauma and different memories that people associate automatically to NHS buildings, especially considering that in this study we were talking about people kind of being detained by the NHS. So that was a really important in terms of identity. But I think in the caption workshop specifically, we were very reassuring to people that their images would not be shown without their captions. And that was really important to us. We, I guess, worked with them to kind of help them document what their intentions were with that image. And I think kind of just really being led by them. Some captions were incredibly long and some were incredibly short, and either is okay. So I think just really allowing them to be kind of in the driver's seat and not kind of taking control for them. Some people preferred the researcher to write, some people wanted to write themselves. And I think the level of involvement people wanted from the researchers really varied in the participants in this study. And I think just recognising that variance and being led by the participants was really important for us.
Being participant-centered. Very interesting. Thank you. And Sasha, Manon had another question also for you, Dr. Mutamba. And really, was they were wondering about whether stigmatization affected the study in any way. And I would like to add my own question to that. Did you observe any changes in awareness and attitudes towards individuals or community residents with psychosis or mental illness over time during the project?
Thank you. I'll start with your question, Laura. I think that will probably be on an anecdotal basis, because we are not testing for community attitudes or change in stigma. And part of the project is actually to create awareness. So that I might not be able to speak to at the moment, but relating to Menon's question, our experience of stigma has been more like a double-edged sword. Engaging service users, the SCAPE-U facilitators, actually in ways, and this is the experience of the team, in certain cases has actually resulted in the community around the service user and the family itself realizing that, okay, someone might have developed this illness, but they can actually be better and be as functional and useful as the SCAPE-U facilitator. And so I think you might have seen it in the pictures. They put on orange t-shirts and move around with them. So in a way, it has helped deal with the SCAPE-U facilitator stigma, but also stigma in certain families and communities. But that said, for certain families and service users, they don't want to be identified with having someone living with mental illness come to visit them. And so that has been the experience for some of the SCAPE-U facilitators and the You Belong team. So I think that is something that we are continuously learning how to adapt to, that stigma manifests in many ways. But stigma is one of the outcomes that we are assessing, the self-stigma and experience stigma, and we shall see what the data tells us. Thank you.
Thank you. And Nafi Poswa, my apologies for saying this was someone else's question. And I'd like to, they had another part of their question, which relates to what you were just saying. How much more work do you think still needs to be done in African societies to open the community to understanding mental health conditions?
That one is a lot. but I think, yeah, it is a lot. We still have a lot to do, but I still think there's a lot of opportunity. I, for one, think that when you engage communities and families the right way, you deal with you find it easier to deal with stigma than, for example, amongst healthcare providers, amongst professionals. But in the African community, I think there's a lot more work to do, and that's why, as you belong, even this SCAPE-U is trying to see how we can collaborate with people with lived experience, because I think the powerful message of someone living through illness speaks a lot to many people. It spoke a lot to the primary health workers and community health workers who are being trained by the SCAPE-U facilitators, and I think it speaks a lot to the families. So I think more engagement with people with lived experience, families with lived experience, professionals with experience of working with people with lived experience can open a lot of windows. That's my thinking.
Thank you. And Nimra Khan has a question for you, Dr. Mutamba and Dr. Mooney, both. Thanking you both. But what are the types of challenges you foresee if you want to scale this intervention in Uganda? And after, I would say, Roisin, that's an interesting question potentially for you as well.
Okay, I'll go first. I think the challenge is that this is really a new concept of having of actually working with people with lived experience, and also the dynamic of having them work with you, because it involves a lot of support to people with lived experience to actually do this work. It's both challenging for them in as much as it is beneficial. And we are learning a lot of these processes, because our aim is actually to scale up SCAPE-U, and because it's a pilot study. So we're doing a lot of process evaluation to know how best to actually collaborate and engage SCAPE-U facilitators or persons with lived experience, so that it is easier to scale them up within the health system, because we still believe that it's easier to scale up when it's a health system-led intervention rather than a project-led intervention.
Yes.
Thank you.
Thank you. Roisin, what are your thoughts?
Yeah, I think I would agree. We have another project at the moment called CoFix that Nimra actually works on with me, where we're currently using Photovoice again with peer researchers, and I think it's really important to make sure that the support is there and available for everybody involved. I think that Photovoice provides an incredible opportunity actually for people to reflect and share their stories in a different way. And I think we've seen a lot of evidence that is very impactful in the moment. But I think harnessing that impact for its legacy is really important also. And just ensuring that the support's there for when those new insights happen, that we can kind of channel people to the right places, and that there's capacity in the system to facilitate kind of those stories and new insights to continue to be supported.
Thank you. I realize we're almost at time. Is it all right to have another question and continue? Yep. All right. So this is for you, Roisin. After the research has been done, what do you think would be the best way to share your results with the community, bearing in mind that there are a variety and diversity of participants? This is from Jella Richards.
So I think the Photovoice exhibitions themselves have been incredibly powerful. It's been really heartwarming to see some of our participants from the research come to those and bring their family and friends along with them, and kind of travel quite some distance actually sometimes to attend those. And I think I often like to have quite a big assistance budget in my research, because I think sharing food is always something that really kind of creates moments and memories and helps to build those trusting relationships in communities. So, having quite a nice kind of, exhibition event where people feel valued, I think has been a really nice way of giving back to the community. But I think making sure that things are accessible. So, as academics, we often publish our results in academic journals and to kind of fellow academics. But for this work, we were very fortunate that there was a video commissioned, which I actually skipped in my slides to save time. That's available online, which kind of really shares the process that we underwent with this research. So I think it's really important not just to share the outputs of the findings, but to make sure they're contextualized in terms of why and how you got to those conclusions. to really kind of bring everyone along in the journey with you. So I think just having a variety of options to reflect that variety of diversity. So we also have like an audio documentary that sits alongside the exhibition online. So there's a few different quite immersive ways that people can interact with our findings, whichever way they wish to.
Thank you. Any last questions at this time? Well, the video will be posted on YouTube, on the department's channel, and they will be welcoming comments at that time. I want to thank you for inviting me to be chair for this informative and inspiring presentation. Thank you so much.
Thank you. Thank you, everybody.